Imaging of the kidneys with DMSA provides a real functional display of the kidneys. It's not an anatomic image, it's an image of the uptake in the tubular cells of the kidneys. The learning objectives of this talk include indications for the test, methodology, some examples, and conclusion. The different applications or indications for DMSA scintigraphy of the kidneys, and they include a postnatal assessment of renal abnormalities detected by ultrasound, hydronephrosis, pyelonephritis, assessment of split renal function and duplication, multicystic dysplastic kidneys, cysts, ectopia, transplant, trauma, renal vein thrombosis, and infarction. To give you an example of a population being examined with DMSA, this graph shows the frequency or the number of patients as a function of age. And as you can see, most of the indications are in the younger age group, although you can see a secondary peak in the early teenage group as well. This minimal or no patient preparation prior to this study. The dose of DMSA is 0.05 millicuries per kilogram or 1.85 megabecquerels, with a minimum and maximum doses shown there. After the injection, imaging is taking place between 2 and 4 hours, or even later. Imaging can be performed using planar imaging, pinhole imaging, or SPECT. DMSA is taken up by the proximal convoluted tubules according to renal blood flow, and we have demonstrated this using intra-arterial microspheres. The renal uptake of DMSA is about 40% of the administered activity at 4 hours, and it continues to go up to about 75% at 24 hours after the administered activity. Very small amounts of the tracer are slowly excreted in the urine. Because the tracer is taken up and stays in the kidneys, is an ideal agent for static renal scintigraphy. What you see here is a frozen section autoradiography from a right kidney after injection of the MSA, and you can see the dark silver granules associated with the proximal convoluted tubules. The distribution of the MSA reflects renal blood flow, and this is an example to show when an additional kidney is introduced in this rat. And you can see that the tracer is distributed equally among the 3 kidneys. Here's an example of a DMSA SPECT, and this is a very essential view prior to interpretation. I would prefer this instead of just looking at slices. It's important to see the volume in 3D before making a regional assessment. One of the features of radionuclide imaging, and like in DMSA, is that the injected volume of the tracer and the mass administered is very, very tiny. An example, for a 1-year-old that weighs 10 kilograms, the volume administered of DMSA is 0.03 milliliters. And the actual mass of substance injected is 0.22 milligrams. So one would expect not to see any pharmacologic effect, allergic effect, or osmotic or toxic effect. So this is very innocuous and safe. Radiopharmaceutical administered doses in nuclear medicine have always been determined in the past by tradition, old schedules, practitioner's preference, age and type of equipment, and lack of familiarity with children. Particularly in the younger age group, the package insert of the radiopharmaceutical does not provide information about recommended administered doses. And so practitioners have used their personal criteria to determine what dose to be administered. More recently, in the last several years, there has been a consensus, an expert consensus guidelines developed, and this is currently accepted worldwide. As you can see, this table shows several radiopharmaceuticals, and the MSA is shown here, and the administered activity is shown by kilogram of body weight. There's a minimum and a maximum activity recommended. This can be found in the Society of Nuclear Medicine and Molecular Imaging website, and it's a really nice tool if there's no information otherwise. Planar imaging, which is most frequently used, includes posterior projections and possibly added left posterior oblique and right posterior oblique projections. The planar imaging will show the number and position of the kidneys as well as the location, and it provides a functional morphology of the kidneys. It shows the differential renal function, which in the normal range is between 45 and 55%, right versus left and vice versa. It allows you to detect duplex kidneys, upper and lower function, and if more detail is needed, pinhole scintigraphy or SPECT are important to be able to clarify. Here's an example of the gamma detector using a parallel hole collimator. And as you can see, the object here projects on a 1-to-1 scale to the detector. So there's planar distribution. In opposite to that, if you use a pinhole collimator, the object is magnified and the image is distributed over a much larger area of the sodium iodide crystal. And this provides increased resolution at a cost because the sensitivity changes with distance. The sensitivity is lower than with a parallel hole collimator, and the image size changes also with distance. That means if you go closer, you get a greater magnification than if you go farther away from the collimator. This is an example of a doll showing the pinhole collimator over the area of the kidneys. And as you can see, the image of the object is is projected over a larger area of the crystal. Another example of an image with pinhole is in this 13-day-old girl with left hydronephrosis. And this patient was administered the MSA and imaged 4 hours later. As you can see, even though the kidneys are very small, one can see the hydronephrosis on the left side and calculate the distribution right versus left. In a similar size child, a 29-week premature baby, image with a parallel hole, you can see that the distribution can be determined, and you see an outline of the whole body. Normally, you don't see this in the older child. This background represents a degree of renal immaturity. As a patient grows older, there will be much less background in the field. And here is an example of what happened in a very tiny, immature child. And this patient has hydronephrosis. Imaging was done at 4 hours after the injection. And you can see there is some retention of the tracer in the pelvic calyceal system on the left. And you can see some tracer on the bladder, which is usually not seen as much in the normal case. And the distribution split function shows 57% to the left kidney and 43% to the right kidney. But this is misleading because this split function is calculated including tracer in the urine. So one can wait several hours to let all of this urinary activity drain. And in this patient waiting 24 hours, the image shows no retention of tracer anymore in the pelvic ileal system, and it's all clear, and the distribution now is more faithful than on the 4-hour. So you have a 50-50% distribution, while on the 4-hour image, the left kidney appeared to have more function than the right, but that was not the case. So it's important to keep in mind that in very young patients or patients with poor function, it is possible once is looking for split renal function to be misled. So it's best to wait longer, allow the urine in the tracer in the urinary system to drain, and then the MSA remains tucked into the proximal convoluted tubules, and you get a much better idea of split renal function. The question that has been asked is, can we, doing the MSA scanning, differentiate renal scarring versus reversible changes? It may be possible in some cases. In the case of scarring, there is a clearly localized loss of renal cortex, the sharp edges, there's an apparent loss of cortical volume, and it's not reversible. So one can be pretty confident in that case that this is a scar. How do I go back? Okay. On the case of acute pyelonephritis, the lesion will show ill-defined edges, but with no apparent loss of volume. So one can see the outline of the kidney without a very sharp angle. It can be reversible, but it also can progress to scarring. In this case, the defect that you see here and here is reversible after 2 months of antibiotic therapy. So you may be able to differentiate, but it's not an exact science. Here we can see an example where the left upper pole has a defect during the acute phase, and then after some time, you can see that there is recovery. Contrary to that case, this other case shows early lack of function, quite extensive on the upper pole, both in the anterior and the left posterior projection. And over time, this defect remains, and it's very sharp. So this is what one can be more confident that this is scarring and not an acute change. Pyelonephritis could be focal or diffuse. These are two examples where you can see that the infection is pretty diffuse along the left kidney, while the right kidney here is normal. And on this other case, the right kidney shows diffuse acute pyelonephritis. So it can be focal, small, medium, large, or it could be diffuse. Here's an example to show the difference between planar imaging with a parallel Hall collimator and pinhole imaging. I think you can appreciate that in this very young 35-day-old boy with hydronephrosis, the outline of the kidney and the spatial resolution is much better with a pinhole collimator than with a parallel Hall collimator. There's no question about that. Here, again, an example of planar imaging with duplication of the right upper pole. And when you use pinhole scintigraphy, you can see the details much more clearly. Not only the difference between the upper and the lower pole, but also internally, you can see the folds of the cortex, which is, if you look at high-resolution images, is something you would expect. especially very young. Here there are three examples of renal duplication with the MSA. And here in this case is bilateral renal duplication with the upper pulse showing lower function on the lower pulse. And in this other case, duplication of the left kidney is very clearly seen, and the right kidney, which is functioning more poorly than the left, the lower pole shows decreased function because of duplication. Here, duplication is seen in the upper pole and very clearly seen in planar imaging as well as SPECT, much clearer on SPECT than planar imaging. An example of a 1-year-old weighing about 10 kilograms, the administered activity, as I mentioned, is relatively small. The activity administered will be higher with a patient that weighs more than the baby. What is interesting to point out that in a very young child, it's normal to see what you see here. Not entirely normal, but you see these areas that appear to be a defect. Those are normal fetal lobations. Here, 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 and here. These disappear with age. They must therefore not be confused with cortical defects. One particular use of DMSA is to find a kidney that cannot be seen with other techniques. For example, this 80-year-old had an ongoing urinary tract infections and urinary incontinence. However, the ultrasound examination showed a solitary left kidney here in the posterior projection. And obviously that kidney is not normal, but this is not the issue. The issue is that there is another kidney, which is ectopic, lower down. This is from the anterior projection, that's from the posterior projection. So indeed, this was not a solitary left kidney. It was a kidney, but it couldn't be detected in this case by ultrasound. Here's a more dramatic example of an ectopic kidney, and this is probably seen quite well with ultrasound as well. But if the ultrasound does not find the ectopic kidney, DMSA is useful to identify the functional renal mass in an ectopic kidney. In the cases of multicystic dysplastic kidneys, these are four examples of cases where the patients have multicystic dysplastic kidney. And you can see the range of possible findings from total absent uptake of the involved kidney to minimal uptake to a huge hydronephrosis with some uptake on that involved kidney, or even some uptake which is not absent or not grossly distorted. So there is a range of findings on the MSA in patients with multicystic dysplastic kidneys. SPECT is superior to planar imaging for the assessment of renal parenchymal function or defects. And I highly recommend that one resorts to SPECT on a routine basis to optimize the ability to detect abnormalities. Different methods by different manufacturers will tell you what the method of acquisition is. What we have been using in the recent past is a 128 by 128 matrix with images taking over 360 degrees around the patient, and this requires a 20-minute acquisition. The multiple intensity projection image, which I showed you before, is critical to get a 3D evaluation of the kidney before doing the slices. Slicing obviously can be done in the transcoronal and sagittal planes. Typically, in the recent past and even today, reconstruction is used by filter back projection. However, modern systems provide with reconstruction with OSEM, with resolution recovery, which is superior, as I will show you in a moment, to filter back projection. This is an example of a mock of a patient, and the camera on the top and the bottom, both of the cameras will be rotating around the body and taking multiple images, which then are reconstructed, and you can display. This is a display we put together to help the referring physicians to see the entire study in one image, so you don't have to scroll. And in this patient, you can see the transverse project slices, the coronal, and the sagittal images. Here you can see a comparison between planar images on the left side in a patient that was suspected of having a pyelonephritis of the right kidney. And this was seen later on the next year, clearly on planar imaging. This is a right kidney, and SPECT shows a very clear discontinuity of function that is much easier to accept than this, although this is very clear as well. And you can see it in all projections. The patient got better, and you can see that this defect has essentially disappeared over time. It still is suggested a little bit on the images, but there's clear evidence of recovery of renal function, very clearly seen on SPECT. Now, this image is very important, not because there is a cystogram on the left or a clear defect on the upper pole here. This patient had fever, 10-year-old, vomiting for 3 days, urinalysis, chest x-ray, strep tests were all negative. The blood cell count was 16.75. The patient developed diarrhea, suprapubic abdominal pain, and was treated with analgesics. So clearly, this patient had pyelonephritis with reflux to the right kidney and the upper pole. But it's important to remember that vesicoureteric reflux is not a necessary condition for the development of pyelonephritis. So in the past, most people in the US at least will rely heavily or more heavily on voiding cystography to determine whether or not this patient has pyelonephritis. On the European side, they did not place as much emphasis on cystography. They called this a top-down approach. They will examine the patient with DMSA first. If the DMSA is normal, then they will not proceed to do a cystogram. If it's abnormal and they need to determine if reflux is part of the picture, then they will proceed to do a cystogram. So that approach has been accepted quite well in Europe, and increasingly this approach is also being accepted in the United States, in North America, which is called a top-down approach versus a bottom-up approach. So not necessary to have reflex. The advantage of SPECT, especially using OSEM 3D, is clear. Newer, faster computer systems today allow the use of iterative reconstruction, OSEM 3D, in the routine clinical environment. It doesn't take very long to do this. In the past, people would not use this method because it would be apparently too complex or take too long. There's no excuse not to do this now. So, superior image quality with OSEM 3D, much lower counts. The patient can be given at least half the dose of what is recommended, and one can obtain similar or even better images than with filter back projection. So, therefore, the patient will experience a lower radiation exposure with OSCM 3D reconstruction than with conventional filter back projections. So, in one study, we show clearly that you can inject half of the activity compared to filter back projection with 100% counts, and the image quality was better with OSCM 3D. In both cases, the split renal function was comparable. There was no difference between filter back projection or OSCM 3D, and the same happened with renal length and split function. Here is an example where the patient has a SPECT using the full counts, and you can see there is a defect in the upper pole, and the right kidney appears relatively normal. When you use OSCM 3D, and you can use half the counts or half the dose, and the images, you will agree with me, are much sharper than with a filter back projection example here. This is the same patient. And the right side, you can see the normal cortical, the columns of Berg 10, that are not very well seen on filter back projection. So this is half administered activity. This is a full administered activity, and clearly there is a plateau. You don't need to administer more. You can administer less and obtain superior images. So in the practice, you can use half the administered dose, or you can use half of the acquisition time from 20 minutes to 10 minutes, or you can use a combination of both, reduce the dose and reduce the acquisition time, which is clearly advantageous. Another example of a 17-month-old with bilateral reflux, etc. And you can see that on the filter back projection with full counts, you can see there is a smaller diseased left kidney and a more normal right kidney. But when you use OSCM 3D, there is much more clear definition of the defects on that left kidney. The left kidney showed diffuse cortical thinning on ultrasound, but clearly it's not diffuse cortical thinning. There is focal and diffuse cortical thinning. So this image is very, very important to outline the functional image of the kidney. Another example with filter back projection using full counts, there's no question there's a problem, defect on the lower left kidney. Much better seen with half counts using OSCM 3D. There's no question about that. So again, I would highly recommend SPECT and OSCM 3D with resolution recovery. Renal size, renal volumes can be also easily quantified using DMSA SPECT. And we look at a large number of patients that were considered normal in retrospect, and we measure the renal volume using DMSA SPECT. And you can see here left kidney and right kidneys, and as a function of body weight, and you can see that the volume of the kidneys, as you might expect, increases with age. And in this publication, there's a table that tells you what the normal ranges are for left and right kidney as a function of body weight. So this can be used routinely because it's automatic. And one clinical report is shown here where you can see a SPECT in the different orthogonal sections, slices, an image of the kidneys with the renal length and the calculation of both renal length and the volume. So this is reported routinely on the DMSA study. and not only the split renal function here and here, as well as a 3D percentage. So it's a really easily implementable method and adds additional information about the kidney, not only the right versus left, but the length and the volumes are calculated automatically. So in the case of renal vascular hypertension, where the patient may be suspected of a renal artery stenosis, the MSA plays a role. Renal scarring is known to be associated with hypertension. 21% of a number of patients have renal scars. The sensitivity and specificity of the MSA is pretty high, at 94%. The positive predicted value is 63%. The negative predicted value is 85%. And the MSA expected in this population of 159 patients demonstrated abnormalities in 1/10 of hypertensive patients. So it's a good tool in the armamentarium to determine if hypertension is caused by renal abnormalities. We also use AC inhibitors, captopril, which decreases the tracer uptake of the affected kidney. And normally, the balance of the GFR and vascular tone between the preglomerular and the postglomerular arteriole is disturbed in renal hypertension, and pressure in the preglomerular arteriole is decreased, and filtration pressure can be maintained by postglomerular vasoconstriction mediated by the renal angiotensin system. The AC inhibitor decreases not only glomerular filtration rate, but also decreases renal blood flow, which is assessed also by the MSA. An abnormal study after using angiotensin converting enzyme inhibitors results in an increased split renal uptake and identifying focal renal defects that are not seen on baseline studies. Captopril can be given orally at 1 milligram per kilogram, and Aprilat is given intravenous at this dose. And unlike captopril, one has to really watch very carefully about potential hypotensive crisis. And so I would recommend using captopril instead. In both cases, the patient should be well hydrated and receive a saline infusion during the study. Blood pressure must be monitored every 10 minutes, and always watch for the possibility of a severe hypotensive crisis, particularly with Aprilat. Here's an example of a patient that has hypertension, 9-year-old female, and the patient had a normal ultrasound with Doppler. However, you can see the DMSA showing cortical abnormalities on the left side, not only on the projection image from the back, but also focally seen on the slices. A patient here is a premature 1.5 kilogram newborn who developed hypertension after the withdrawal of a umbilical catheter. And on the baseline DMSA, you can see no evidence of uptake in the left kidney. And after treatment with hydrolysine, you can see there's recovery of function on that side, and this patient hypertension became less so. In conclusion, DMSA imaging is a very unique, safe, sensitive, and excellent method for the functional assessment of renal functional cortex in a variety of indications. SPECT and pinhole scintigraphy are better than planar imaging. Most people tend not to use pinhole scintigraphy because it takes a long time, but I would recommend that we always do SPECT on DMSA. and that we assess the volume with this type of an image before doing the slices. The administered doses of DMSA should be optimized and or standardized. As I showed you before, the North American expert consensus guidelines provides administered doses that are reasonable to obtain good studies both in children and adults. These administered dose charts are being optimized constantly. So in the future, not only because of improved imaging technology, but also by reconstruction technology, the instrumentation and software, perhaps the imaging will be optimized and the dose may be reduced significantly, even though we already are reducing the dose. So in summary, excellent method, very unique. We don't see the anatomy of the kidneys per se. We see the image of the distribution of a radio tracer in the renal cortex. It's very sensitive and highly recommend that you use SPECT all the time. Thank you very much for your attention.